Okay. Hello, guys. Can you all hear me? And if you can,
Yeah.
perfect. Good, good. I can hear you guys. So let's get going. I'm just going to kind of like keep admitting people as we're starting. So sorry, the start is always a little bit hectic because I'm notoriously bad at multitasking. So I'll just admit everybody and kind of introduce everything. We've got Nellah again with us today. I'm not sure if she's joined yet. She just texted me saying she's running a bit late. So Nellah, you there? If you are, just unmute and.
I can hear you. I'm here now. Can you hear me?
You made it. Perfect. So now I'll just keep admitting everybody. Well, why don't you introduce yourself for those who weren't here last time and don't know you?
Sure. So my name's Nellah Grace on social media. I am a final year medical student. So I currently study abroad in Lithuania, but I'm British. I'm also so I'm soon to be doctor in about 5 months' time. I'm also a YouTuber. So I make vlogs, kind of documenting that whole medical school journey. So you can find me on YouTube. And I'm the founder of a agency that helps students to get into medical school in Lithuania where I study, called MedConnect. So that's kind of like me in a nutshell. So me and Ash are very similar in that way. We're both medics, both YouTubers, and both entrepreneurs, also in the medical field, trying to help students to get into medical school. So yeah, that's basically.
We like to keep busy.
Yeah.
So yeah, thanks, Nellah. And yeah, exactly. I mean, I came across Nellah because we both help people get into medical school, and that's what we've been doing for quite some time now between the two of us. So it's peak exam season at the moment, and a lot of people are asking peak interview season at the moment, should I say, and lots of people are asking us lots of questions, and we figured it'd be good to do another one of these sessions because they always seem to go down pretty well, and so we'll be doing, I don't know if you guys haven't come across me before, if you're kind of more Nellah's following. My name's Ash, and I'm a doctor and a dentist in the UK. And similar to Nellah, I do a YouTube channel. My YouTube's nowhere near as big as hers, but I'm more focused on the business side of things, where I make online courses for people, because ever since I was at medical school, I used to help students get into their first choice medical school by doing it through friends and, brothers and siblings of friends. And it kind of just grew from that. And it got to the point where I was having a lot of success and needed to find out, there was only so much I could do as an individual. So I started making it into an online course, and the program that I do, Future Docs, has amazing success. I'm very lucky that, worked hard and had a lot of knowledge and effort put into it, but very lucky that the course is having the effect that it is desired to have in terms of success of getting the delegates into their first choice medical school at the first attempt. So anyway, enough about that. Let's crack on. So yeah, medical ethics. I put a little poll out on Instagram for who, what subjects people wanted to do. And even though we've already done a medical ethics talk, I think it was in about November, we did it with Ryan, which was fantastic. I think people still want more of the medical ethics. I think, understandably, there are about 3 subjects that people really get confused about and really struggle with, and I think that is the reason why, despite us already doing one, people wanted another one. So happy. Yeah, I mean, I will do, I'm here to help you guys. So whatever you guys have decided you want me to teach you, I'm happy to do that. So cool. And on that subject, actually, if you guys want to watch the previous medical ethics talk that we had, I'm just going to put a link in the chat now. And if you guys subscribe, just hit subscribe, and then you'll be able to access the old medical ethics talk, because it's a really, really good one. And we'll be doing obviously just as good today, but that's a really, really good one. And so you guys can see that link now. I'm also going to give you the link to Nellah's YouTube channel So we've got a lot of stuff going on at the moment. I don't know if you guys have seen, but at the moment I'm releasing a series, which is essentially summary of all the key subjects. So there's about 13 key topics that you need to know, and I've condensed the kind of, so for each, on my online course, for each subject, it's usually about an hour and a half, and I've condensed it into like the bare essentials in about 10 minutes per video. So that's a good one to check out. Okay, and sorry, yeah, questions wise that I can see. Yeah, so don't worry, we'll be going for about an hour to an hour and a half, depending on how it goes. And it is recorded, so yeah, I will be putting the recording out on YouTube at about 4 o'clock on Friday. So yeah, and then Nellah will probably put that on her channel as well, because we did last time. Okay, great. So before we get started, let's and remember in the chat, sorry, you can always ask questions, and whoever's not talking between Nellah and myself will be we'll be monitoring the chat and interrupting, and we'll essentially be riffing on medical ethics, and we'll just be going back and forth and kind of talking about the important subjects that you need to know. And sometimes I'll take the lead, sometimes Nellah will take the lead, and we'll kind of just interject once we've got good little tidbits to add. So yes, before we get started, there was just one thing I wanted to ask you guys. So just to get a feel for where to pitch this talk, I like at the start, so if you guys go in the reactions, and what I'd like you to do is just tell me with a yes or no. So are you currently applying to medical school? So at this stage, are you kind of in the interview period yourself, or so yes if you are, and no if you're applying next year, probably starting in September or later. So let's just see some yeses or nos depending on how you're doing. Let's see, anyone for yeses or nos? Can you see any?
I think it's about 50-50, which is good, because it means that the 50% of you that are waiting for interviews will get a lot out of this, and the people that are also wanting to apply maybe next year after will also get a lot out of this. So that's good. I think it's about 50-50, yeah. Great.
Okay. So then, okay, let's leave it for that one. Now, for those of you who are currently applying, as in, so you're currently kind of in the interview phase, how many of you, whether it's a rejection, interview offer, or even, you've got as far as being accepted, how many of you have heard from all 4 of your universities? So how many, whatever the answer is, have you actually had a response yet? So yes, if you're waiting for, so yes, if you've had all your responses, no, if you're still waiting for some. Okay, so a lot of no's, a lot of people. So because, yeah, a lot of my students have been a bit worried about hearing back, and especially at the moment, it's I think they're being delayed a lot more than usual as well. So yeah, not only are we kind of exhibiting a bit of, or experiencing a bit of a lag, it's still early. I mean, I remember when I applied, I don't think I got my, I think it was really late in January when I got my offers to come and interview, and then I didn't get my final offers until mid-March, I think it was. It felt like forever. So good. Okay, so if you haven't heard back yet, take solace, because it's not, there's still plenty of time, plenty of opportunity to hear about it. Okay, right. So without any further ado, let's get going. So, medical ethics, obviously a really, really important subject, and it's something that will come up at interview and is very feared at interview, but also something that is important throughout your medical career. There will often be circumstances where the ethics of whether to treat or not to treat come into play, and there are lots of circumstances where you kind of are in maybe a legal dilemma or an ethical dilemma as to what you should do in a given circumstance. So knowing the legalities of it, the legislation, and knowing kind of what you should do in what situation is really important. And it's important to deliver care in a manner that's that's right, really. I mean, it's hard to define what is right, but we as doctors, we have tried to develop a system and some guiding principles to help people treat and know when it's ethical to do so. Okay, so I think we should probably start with some definitions. And the main two subjects that will come up in medical ethics, well, on the subject of medical ethics at interview, are consent and capacity. So consent is where a patient gives their permission for something to happen, and this is, in a medical context, is say a treatment or an investigation or an examination maybe. And in medicine, the important thing is it's not just consent. We have something called informed consent, which is what we'll come on to later to talk about what exactly specifies informed consent. And then the other thing that we take that we need to know, in a good definition, is capacity, and that is the ability of the patient to give consent. And it's usually based around, there's some criteria that I'll come on to, but it's based around so their understanding of what they're about to undertake and their ability to understand. And I'll say now, this is all recorded, remember, so I'll put this out on Friday. So don't worry too much about taking notes. Just, you know, listen, kick back, try and absorb as much as possible. And then if you want to come back and watch it on YouTube, then I would recommend doing it like that, because you tend to absorb more when you just sit and watch rather than just sitting with your head down taking notes. Okay. So we'll start by talking a bit more about capacity, and then I'll hand over to Nellah. So the important thing with a patient in any context is that an adult is deemed to have capacity unless they prove otherwise, okay? And there's a piece of legislation called the Mental Capacity Act of 2005, and they specify the circumstances or the prerequisites for a patient to be deemed to have capacity, okay? And those are essentially four things. And those are that they can understand the information that's given to them. And that might mean that you have to explain it in a variety of ways to them. They might not understand it the first time because they might not be of an intellect to understand it, but as long as you can make them understand it in a way that's communicable to them, then that's okay. They need to be able to retain the information, so they can, you know, actually not just understand it, but they can take it in and remember it. And then they also need to be able to weigh up the risks and benefits, so understand the pros and the cons for undergoing the treatment. And then they have to be able to communicate that decision back to you. And again, that doesn't necessarily mean that they have to speak it. If for whatever reason, if their ability to speak is impaired, then as long as they can communicate that decision to you in your way, in their way, sorry, of communicating, then that's absolutely fine. Okay. So what I think we'll do now is I'll just ask you a question, because there are many circumstances under which a patient may have their capacity impaired. So what I'm going to ask you now is, in the chat, I'll give you I'll give you about a minute to think and suggest of some ways in which a patient's capacity might be impaired. So we've got age, dementia, mental illness, being unconscious, brain damage, being underage, we'll come on to talk about that. Drunkenness, yeah. Trauma, absolutely. Yeah. Drugs, intoxication, yeah, we've got, yeah, great.
Yeah.
Okay, learning difficulties, yes.
Mm-hmm.
Fantastic. Okay, great.
I'm sorry.
Hello?
Well, yeah, one of my friends is in the list. Can you please accept him?
Oh, yeah, no problem.
Thank you.
Yeah, they're in. Great. Okay.
Yeah.
So, Nellah, I'll let you take the next bit away.
Yeah, so those are really good answers, and they are actually some of the answers that I was going to come on to next. And I think what's important about those answers that you guys have given is to understand that if you look at them, they can be very different. So this goes, we're talking about capacity, that capacity sometimes doesn't always, it's not something that's, you know, done and dusted at one time. It's quite a fluid thing, and it needs to always be assessed continuously. So for example, some of you said someone who's intoxicated or who's on drugs. So for example, right now I have full capacity. I can, like what Ash said, I can understand the information, I can retain it, I can weigh up, I can communicate back to Ash if he was to ask me if I wanted something. However, if I was intoxicated tomorrow, and I was completely, you know, had no capacity, I wasn't even able to understand what Ash is saying to me, I wasn't able to say it back to him, then in that moment, I don't have capacity. So it's quite fluid in that way. So it can be either momentary or it can be permanently reduced. So we have to kind of categorize those capacities in two different things, in two different ways, and continuously assess them, as we said. So some of the answers that you guys have said, like alcohol, drugs, it's temporary. Like if someone has like an acute mental health issue, so mental health issue is not something that, you know, it can be acute or it can be chronic. So if it's an acute, or if someone is unwell and it's affecting their consciousness, which is why we do things like GCS as well. If someone has so that's kind of like temporary, like reduced capacity, and then you have more permanent ones that you guys also said. If someone is has dementia, some of you said trauma, someone has a brain injury that, you know, has made them permanently not able to have capacity. If someone has a learning difficulty as well, is something that, you know, is also a permanent way. So basically the point is that it can be fluid, it's not always the same, so you have to assess it continuously. And I actually had someone not recently, about a month ago or something, that in my hospital where I was on my placement, it was an elderly lady who previously she had capacity and she was able to like make her own decisions, but on that day she'd come in because she had syncope, she'd fallen, she'd hurt her head. So the doctors had to they were asking me, you know, do you think she has capacity? And we had to go through this. Okay, can she understand what we're saying to her? In that moment, her capacity was reduced. So, you know, and she was refusing to go for an MRI and things like that. So we had to make a decision. Do we just send her to an MRI anyway? And we're going to talk about that later on, about how to make those decisions. But so basically it's fluid. So it's important to remember that when a patient though so yeah, Isabel just asked, how do you assess if someone has mental capacity? We're going to talk about that next. It's a great question. So it's important to remember that a patient can make a decision that you think is unwise, but it doesn't necessarily mean that they don't have capacity. So as long as they can do those things, that's why capacity being assessed needs to be something that is very subjective. It's not something that you can be like, well, I don't agree with that decision, so that person doesn't have capacity. So the principles of how you assess if someone has capacity, what Isabel just asked, is what like what Ash just mentioned before. Can they understand what you're saying to them? So when you say, you know, can I take you for this MRI? Do they understand? Can they retain that information? Can you ask them, do you understand what it is that we're asking you to do? And they will say back to you, yes, I understand that I have to go for an MRI. Do you understand why you have to go for that MRI? Yes, because I fell on my head and you want to see what's going on in my brain. Okay, do you understand the risks? You always have to say risk. That's what Ash said before about informed consent. So do they have those things? So let's say you have assessed the patient and you've decided that they can't understand what you're saying, they can't retain the information, they don't know the risks, like what the example I've just used before. This lady, she'd fallen, hit her head, and she wasn't really able to understand what we were asking her to do, why we wanted it. She was just saying no, but she couldn't tell us why. She couldn't understand why we wanted. So we deemed that in that moment, she didn't have capacity. So how do you make the decision then to either do the treatment or to do whatever it is that you need to do? So someone doesn't have capacity. We need to make sure that the first principle in medicine in general is upheld, and that is to just make sure that we're always doing things for the patient's best interest, or we call it do no harm, right? So we should be doing things that are not harming the patient. So that is the first thing. What is the best interest for the patient, regardless of whether or not, when we've decided they don't have capacity. So how do we decide? Well, to decide what is the best interest for that patient. And this is a decision that's made by both us as the medics and also the people closest to them, like their relatives and family. So as medics, we come from a medical point of view, right? So we're kind of communicating with the patient's family, if they don't have capacity, or relatives, about what the best interest is. And again, this is not something that has to be very, up in the air. It's something that can be actually legalized. So we have two ways that people can make a decision for someone else. So we've got something called a medical proxy. So a medical proxy is when someone who maybe has a disability, or they have, a learning disability, or they have like a cognitive impairment, and they will have someone else who's nominated to make those decisions for them already. And that's because, they can't decide for themselves in general. And then you have something else called an advanced directive. And this is when, let's say, for example, me, now I decide, if something ever happened to me, to my husband, and I say, something ever happened to me, I want you to be able to make that decision for me. If I ever got into a coma, if something ever happened to me, can you make the decision for me? So when I'm of a sound mind, and I request that someone else can be given the power of attorney to make the decision for me if I'm ever compromised, that is called an advanced directive. So that's two different things. Sometimes people have a mental, disability, and they can't make a decision for themselves, so they have a proxy, someone else to make those decisions. Then there's another time where someone else like me who just decides, oh, I just want my husband to be able to make those decisions. So this is when, so those times are the times where someone else can make that decision. So it would now be between the healthcare team, like us, the medics, and those people or those family members to make that best interest decision, if that makes sense. So how do we know what the best interest is having that conversation. So from a medic point of view, we would assess everything. So their medical history, their current situation, what is the likely prognosis, what is the, is it really going to work? Whatever it is that we think we're going to treat them with, what's the outcome? Is it going to be better? Is it going to be worse? So we basically assess the whole situation, the whole picture from a medical point of view. But as we know, like people, the definition of health, right, is not just like a medical health, is also the social aspect of things and understanding that. And then when the family comes in to kind of have that communication, because a person is not just their medic, the medicine problems. A person is a dynamic person. So we have to also weigh up their cultures, their beliefs, their background into the decision-making process. And that comes from sometimes, or a lot of the times, from the family, from the relatives, from the people that are appointed, because they will say, this person told me that if they ever came to this, they would want this. That's something that we take into decision. It's not like a written legal thing that, if I get into, I'm just using a coma as an example. If I go into a coma and then my best friend comes and says to my doctor, oh, she always told me that she would want you to not turn it off. That's not like, it's not legal, like I have to follow that, but it's something to keep in mind when people are talking, just in case that was, true or whatever. So it's basically having that kind of communication between the two of, the medics and also the people around them, because we don't know the patient personally. So we have to have that kind of dance between them to know what the best interest is. And then that way we can make a decision. But there are times when a decision doesn't have to be made straight away as well. So sometimes in your questions and interviews, there might be times where maybe someone is drunk, right? And a huge major decision needs to happen. And this decision can actually be delayed until this person gains their capacity back. If you can do that, then it's important to also, to weigh up the risks and rewards. Like, okay, we can probably wait a couple of hours. This person might regain their capacity and then they can make the decision for themselves. Obviously, if it's an emergency situation where it's life-saving, we have to make the decision. This is where these comes in, the best interest. But sometimes when, life-threatening, I mean, a big decision has to be made, but it can be held off until this person, if it's a temporary kind of capacity reduced, then we can do that as well. So that is all incorporated into understanding what is the best interest. And because the best interest for a patient could be not making that decision in that moment. It could be holding off 8 hours before, you do something that could potentially change their lives, and then they could regain their capacity. So it's going back and forth with that idea as well.
Yeah, absolutely. Best when you're in a situation where you're kind of acting on a patient's best interest, it's always a communication process with the family, what they think they would want, what's reasonable, what's likely to happen, what the kind of laying the situation bare and understanding the realities of it. So so a few questions that we've had at this point. Firstly, An advance directive as well, just to mention, it's also not just for who you want to help, but like what you would and wouldn't want to happen. So for example, I could say something like, if I'm in a vegetative state and after 3 months it doesn't look like I'm going to improve, then I would like, to stop life support or something like that. It can be a person as well as a thing or a circumstance. So let's see what questions. We've got quite a few questions. Some of these things that you guys have asked are actually going to come on to talk about, and circumstances in which, if capacity, if the patient doesn't have capacity, what we do, or kind of along the lines of what Nellah just spoke about. We'll go into more depth about that. And then, so, I mean, what is it? Is it a piece of paper? It's a legal document that you get drawn up, a bit like a will. You get that drawn up by a solicitor, and they have that. And then, so I saw, what if the medical proxy lacks capacity? Well, then of course it just goes back to as if the patient lacks capacity. And remember, so the things to remember is like Nellah said, capacity is fluid. So as she was saying, that somebody might have capacity and then lose it later, not be able to, not have the capacity to give a decision after. The opposite can happen, where the patient might have dementia, but they might still be in early stages of dementia, and later they might have lucid periods. Lucid being where they a clear mind and of sound mind, should I say? And then they are deemed to have capacity in that instance, and whilst they have capacity, they are able to make decisions. Okay, let's see. You have to have proof of it. So yeah, there'll be a piece of paper to say, if you're a medical proxy, for example, there'll be a piece of paper saying it. Same, and for advanced directives, the same as a will. You have that on a piece of paper somewhere that's verified. So what?
Usually it's in there, like medical file, when something is very important, like someone has made that decision. It's like a DNAR kind of thing. It's usually it's in their medical documents that they have this.
Exactly. Okay, great. So I think that's so most of the questions answered. If not, it's something that we'll come on to, and we'll have a bit of time to unmute and talk about questions that you might have later. Okay, so we kind of touched on this, but let's go to the core principles of capacity. Okay, so like I say, it's really important. A really important aspect is that, number one, a patient is assumed to have capacity unless proven otherwise. And as Nellah said, the way that we ascertain that is that we have a conversation with them, and we speak to them and find out whether, are they understanding what I'm saying? Are they fully aware of what the treatment involves? And that might mean that you might have to explain it to them in very simple terms. That it doesn't mean that they have to have a technical understanding of what the procedure is, or know exactly what the ins and outs are. Just know enough to make a decision on it. And they understand, when they're speaking to you, it's clear that they understand kind of what the factors are, risk-wise, benefit-wise, and they're able to communicate that back to you in a sensible way and give a rationale for their decision. Okay, so yeah, and we assume that they have this, unless during that conversation they say something and you think, oh, they haven't understood this, then you start to question whether they actually have capacity. So so that comes on to my second principle, which is you might have to try different ways to make them understand. They might be deaf, you might have to draw it or write it down for them. They might just not be particularly intellectual, so you have to really spell it out to them in very basic terms. And yeah, as Nellah said before, and the third principle is that just because somebody makes what you think is a poor decision does not mean that they are deemed to lack capacity. Okay, so if they choose something and they understand it, they understand the pros and cons, they've weighed it up, and they can communicate to you reasons for not wanting to do that, even if it seems unwise or a foolish thing to do, then as long as they deem to have capacity, they have the complete right to refuse that treatment. Okay, and the final thing is that capacity is situation dependent. So an example would be for, we'll come on to kind of capacity and consent in children, but a good example is, for example, a child can probably understand what having their blood involves, so they can consent to having their blood taken. Whereas, for example, they probably don't understand the consequences and the risks and the ins and outs of having an operation. So that would be something that we would ask their parents to consent for. And then, like I say, consent is one thing, but in medicine, it's informed consent that we're interested in. Okay, and for valid informed consent, we must have 5 things. So to give consent, the patient must have capacity, and as we said before, aware of the risks and benefits and the likely outcome. It must be delivered in a way that they understand, so similar to what I was saying before. So to have valid consent, the 4th and 5th ones are important. So it means that they have thinking time and the opportunity to ask questions. So they need a bit of time to take in what you've said, think of some questions that they might want to ask you about the procedure, just to help clarify things further. And the final thing is that you have to respect the patient's decision, and you cannot say it in a way that's coercive or trying to put them off a treatment or tempt them into having a treatment. You have to be as non-coercive as possible. And that seems and sounds quite straightforward, but actually is very hard to be impartial when, as a doctor, you know that the best thing for a patient, if it was you or if it was your parents, that you'd want them to have an operation, but maybe they're reluctant to have an operation for various reasons. And actually, it's very hard to be impartial. And a lot of doctors, even subconsciously, will probably say things and weight the pros and cons, or the way they word the pros and cons. They'll do that in a way that maybe inclines more to one thing, and to either having or not having the treatment. And you have to be very careful about doing that, because it's very easily done. And then another important aspect is, what do we do if a patient withholds consent? Well, if a patient has capacity, then they are completely within their rights to withhold consent, and that's all there is to it. And if they ask you a question about a patient having withheld consent, I would always say, well, that as long as they have capacity, they're within their rights to do that. I would check that they have fully understood the consequences of not undergoing, and it's not just the treatment, it's also, procedures, investigations, examinations, or any medical intervention, but check that they've fully understood the consequences of it. And as long as they're refusing it with their eyes open, then that's absolutely fine. And again, remember that just because they have taken a decision that is seemingly unwise, that does not mean that it's not an indication that they are lacking capacity. Okay. Now, any questions that you spotted, or any good questions?
I think most of the questions we're actually going to talk about later, about children. And then, so someone was asking about if, I don't know if that has to do with consent, so about like translators and stuff. So sometimes maybe if you want to get consent, but there's no translators, they do have translators in hospitals, official translators, but sometimes, I don't know if this is actually allowed or not, but I know that in practice, a lot of the times it's just another doctor can speak the language and then they just go and translate. But they do have actual translators as well, for if that's like a barrier to consent.
Yeah, I mean, officially, a translator is the best way to do it, but I mean, in A&E, I get it all the time. You hear it on the tannoy, you're like, bing bong, do we have a Spanish speaking nurse who can come and help out? Or, and it's every hour or so, there's a different language called out. And it's quite funny, actually.
Exactly.
Yeah, I speak Spanish, so like once in a while, then when they put it on, I'm like, oh, I speak Spanish, and like a little chance to show off.
It does. It's kind of exciting when you can speak a language that you're like, oh, you don't need a translator.
Yeah, mix it up a little bit. Do my consultations on language.
Yeah, we'll answer some of your questions, and it's actually a lot of the questions is actually the next part that I was going to talk about. So it's about the consent in children. I see some of you having a discussion about Gillick competence and also just the Fraser guidelines. So I'll kind of touch on those things so that we understand them both. And it's not something that you're supposed to have, a huge understanding of, because it's they're quite complex things, but you should have a basic understanding of them and know the key words, like you mentioned, the Gillick competence and the Fraser guidelines. So just to kind of talk about them. So Gillick competency. So when you're having children, and you have about children's ability to give consent, right? So Gillick competence says that children are able to actually give consent to treatment if it's in their best interest and they have the capacity to do so. So just in that definition alone, we see that obviously it's about best interest and it's about capacity. So it goes back to what we were talking about before. We as the medics need to be able to then measure if the child has capacity. So the children can consent to treatments, like I said before, things like, can I take your temperature, or taking bloods or things like that, because the child is the patient. So when you're talking to a child, usually the parent is in a room, but you're talking to the patient, to the child. You're not talking to the parent to give consent. You're talking to the child as long as they've got capacity. So it's up to the doctor to decide whether or not this child is mature and intelligent enough to have true capacity towards the action that you want them to take. So there's three things that they must understand with these laws were kind of established. So it was, do they understand the nature of the treatment? So whatever age they are. So do they understand the nature of what it is that you want them to do? And again, the understanding bit can go back to before. Can they tell you can they say it back to you? Can they retain it? Things like that. Do they understand the risk and benefits of the treatment that you want to do, and the alternative treatments? And this is really up to us as well to be able to explain it to them properly and to be able to communicate that well to them. So if the doctor decides that this child, based on these things, has capacity to make this decision, then we say that they are Gillick competent. If they meet this criteria. So they are a child who has Gillick competency. So this is a term that you should remember, and a lot of you were already saying it. And it's actually named after a famous case that happened where these laws were established. So that means that this child can make that decision for themselves. So it's just like an adult when competency is very situation specific. Ash mentioned it before. So this child, you might deem them competent to make this decision. They're mature enough and they are intelligent enough to make a decision about whether or not you can take their OBS. They can make that informed decision. But if they need to have a huge decision like an amputation or I don't know, something that's more bigger and more life-changing, again, it's up to us, the doctors, to decide, okay, do they understand what's involved in this? Can they assess the risk and benefits? Can they have, do they know what the alternative treatments are? So it's kind of like one of those things where it's very situation specific, and you're kind of deciding as the doctor if they do. And if they are determined, like I said, to be Gillick competent, then their decision cannot be overruled by anyone, even the parents, because they've decided that this child is competent in this. And then we have that's the Gillick competence, and then we have the Fraser guidelines. So the Fraser guidelines are a set of instructions given to practitioners when advising under 16s in relation to sexual health or contraception matters without parental consent. So this is completely different to Gillick competency in that it was made for different things, but it also kind of goes together in that it's about children. So when we're talking specifically about sexual health or contraception matters without parental consent, this is where the Fraser guidelines come into. So some of you might know there's sexual health clinics, in most cities where a 15-year-old can walk into and receive some sort of, advice or treatment or something without their parents' consent. So then for us to actually make that decision whether or not we're going to give this is outlined by the Fraser guidelines. So there's 5 things in this guideline that helps us to understand this. So the first one is that the patient, again, must have the maturity to understand the advice and implications. So when you're talking to the patient, you're assessing that. Do you think they have the maturity? Because a 15-year-old could walk into your your practice, and they, you know, you're talking to them and you realize maybe they have a severe learning disability, so maybe they actually can't understand what it is that you're saying and things like that. So that's something that you're assessing. The doctors so the doctor is not able to convince them to involve their parents. So if you're trying to, you know, you can ask them, you know, is it something, you know, you're sure you don't want your parents to be involved, you don't want them to know, and they say no. If you can't convince them to involve their parents in the decision, then you can't convince them. And then with matters relating to contraception specifically, you have to deem whether or not the patient is about to continue to have the sexual intercourse regardless of your intervention. So if you're a doctor and you decide that this patient, you know, they're probably underage, but if you don't give them this treatment, this contraception, they're going to carry on anyway, then if they do go on to do so, then actually their health, their physical health or mental health would suffer without you intervening. So you must intervene. You must let them have this this guideline, because again, we want to do no harm. We want to make sure that it's in the patient's best interest, even though they're technically, you know, underage in terms of, like, you know, the legal age to be having sex. But medical wise, we would, that guideline outlines that for us. Or like I said, which goes on to the last part, the fifth point, which is that it's the child's best interest to give that advice without parental consent. So maybe the child has expressed to you that, you know, somehow involving their parents would harm them, it wouldn't be in their best interest, whatever. So those are the kind of the Fraser guidelines are outlined to help us make the decisions when it comes to specifically sexual health / contraception matters. And then the Gaelic competence is more to do with the fact that a child is competent to make decision about their health, treatments and things like that, as long as we as the doctors deem them mature enough and intelligent enough, and also to have this capacity. So those are the two kind of separate things. And it's under these circumstances that, you know, for the Fraser guidelines, that the doctors can then provide sexual health or contraception advice to under 16s. So those are two different things. I hope that clarified a little bit. Some of you were asking in those when it comes to children and their capacity. I'm sure there's probably loads of questions about that. And
yeah, I think they were coming through as you were saying it, actually, but yeah. So we'll come on to if a child withholds consent. That's a separate, well, not a separate topic, but another issue. Yeah. Whereas, so if a patient is deemed to have capacity, if a child is deemed to be Gaelic competent and they make a decision to have treatment, it doesn't matter who disagrees with it. So if their parents don't agree with it, it doesn't matter. Once they are deemed to be Gaelic competent and have the capacity to do so, then their decision is final. And they're treated exactly the same as an adult in that sense. And I'll come on to the contrary in a minute and what happens there. But yeah, and as Nellah put really nicely, so Fraser guidelines are there for sexual health and contraception matters, where essentially this is protection for people who are going to probably go on to suffer more harm by not feeling like they can speak to somebody and have some advice. So imagine, you know, a patient who comes in who thinks they might have a sexually transmitted disease, and if they don't get treated, they will go on to have complications that might make them infertile. And we want to remove the doctor's hands being tied from being able to do something to help that person. Okay, great.
Yeah, definitely.
So go on.
No, I think someone just asked quickly, which I think is a good question about the sexual health such contraception matters when it comes to the Fraser guidelines. So if the information is confidential, even from their parents, and yes, confidentiality is always confidential, unless the patient is, again, in harm and it's not in their best interest, I think, then you can, like, for example, if it's a legal matter, like if someone is is being, you know, sexually assaulted and things like that, that's something that you would have to take. And even then, I don't think you tell the parents. I think you just go to the necessary legal or, you know, social work and things like that. But again, that's a whole other thing itself when it comes to legalness. But confidentiality is confidential when it comes to sexual health. Your parents wouldn't know.
Yeah, the only times that you can break confidentiality is when somebody is at risk of harm, and even then you can only break it to the relevant person. So it's always on a James Bond need to know basis.
Yeah.
So you don't tell anybody anything more than they need to know, and you don't tell anyone outside of the remit of people who need to know.
Yeah, exactly. And yeah, you just go according to that. Like someone said, if someone is 3 years old and the parents don't agree, if someone is 3 years old, again, you'd go back to the other thing. Do they understand the nature of the treatment? Probably not. So are they GILIC competent? Probably not. So the parent would make that decision. So it's, you go with those, you go back to those three things. Just with each situation, you have to be able to use those guidelines to then make that decision. If someone is 2 years of age and you want to take their bloods, guess what? They're going to fight you. They don't have the maturity or the intelligence to understand the nature of the thing that you want to do, the procedure. So actually the parents would make that decision for them. So you always have to go back and forth with that as well. So just to answer your question there, Emily.
Okay, great. So few little bits, and then we'll come on to look at some cases. And so start mentally preparing if you're feeling confident and like you want to take on a case. We will put that up in a second. So one of the subjects that we need to address kind of as part of this is safeguarding, right? So safeguarding is something that we have in place to protect vulnerable children and adults. And that could be anything from being at risk of physical, psychological, sexual, even financial abuse. And we have systems in place to protect those people when they're identified as vulnerable. So that usually happens in, well, let's say, for example, in hospital, we have a safeguarding lead, and that is someone who is responsible for all these cases, and you refer them to the safeguarding lead, and then they put in the appropriate, well, it might just be that they need to be investigated because it's a potential safeguarding issue. They might potentially be at risk, all the way to, implementing some help and support, and even, the intervention of the police if needed, if someone is at serious risk. So that's just kind of a small part of it that we need to know. But if there are safeguarding agencies outside of hospital, it's not just in hospital. If you see people out and about that are at risk and are vulnerable, especially as a doctor, it is your responsibility to report that to the appropriate person. And outside of the hospital, we have relevant safeguarding agencies. So depending on the setting, like I know for private companies, they will employ an agency to act as their safeguarding if they come across any issues, and they just refer it to them. And every wherever you are, there will be an appropriate safeguarding agency to refer to. Okay, so that's important, and that goes back to, with these Fraser guidelines, for example, if you have someone who's coming in at the age of 15 and is having sex with somebody and asking for contraception, it's the doctor's duty to ensure that that person is not being sexually abused and it's not an abusive relationship. And just those things to make sure that the patient is safe before we actually engage with treatment. And then we need to talk about, so we've kind of been touching on this. So what about when a child refuses consent? Now, this is where it gets a little bit, I wouldn't say tricky, but it changes a little bit. So remember that if a child's deemed GILIC competent, they can consent to treatment as long as if they have a deemed to have capacity / be GILIC competent. So they can definitely accept treatment and they can consent to treatment. But what if the opposite happens? What if a child is GILIC competent but declines treatment or withholds their consent? Well, that presents a slightly caveated circumstance, because if a treatment is deemed in the best interest of a child and they withhold their consent, they are not allowed to actually do so, even if they are deemed GILIC competent. So the important thing is if it's deemed in their best interest. So if it is deemed in their best interest, we ask the parents to give consent on their behalf. And in doing so, if they consent to it, then we can proceed with the intervention. But then we get into even more hot water. Well, hot water is probably not the right word, but we get into more difficulties when the treatment is deemed in the child's best interest. They refuse to give consent. The parents refuse to give consent. And then if we still think that it's a really important treatment for the child to have, then we have to start escalating it to the courts, essentially. So there is an appeal process where we ask the judge for permission to treat, and if we have to do so, that those are the avenues that we have to go down to prove that it's in the patient's best interest, and go over not just their but their parents' heads as well. Yeah, so
yep.
That, I think that's the majority of it. I'll just go through kind of like a quick summary and some tips for answering questions, and then we'll do some cases. So just the key takeaways are, remember that capacity, so a patient is deemed to have capacity unless proven otherwise, okay? And capacity and consent topics come up often at medical interviews, so make sure that you know the definitions for them and the conditions under which someone is required to, the conditions that need to be met for a patient to be deemed to have capacity, okay? And then remember that we assess a patient's capacity by evaluating their ability to understand the information, to retain it, to weigh up the pros and cons, and then to be able to communicate that decision back to you to show that they actually understand what is going on and what they're agreeing to. Remember that GILIC competent children are allowed to consent to a treatment if they're deemed to have GILIC competence, i.e. they are deemed to have capacity and the maturity to understand. However, they cannot refuse a treatment if it is deemed in their best interests, even if they are GILIC competent, okay? And as I say, we then go to the parents, and if the parents then disagree, then we have to escalate it above to the authorities and ultimately to the courts. Okay. So let's go for some questions, and then we'll talk about some cases.
Yeah, so kind of with what Ash just said as well, which kind of goes into that, someone was asking if it's an emergency situation and the parents go ahead is not readily available, and the child cannot also obviously make that decision, then it's up to the doctors. It's the doctor's responsibility, if it's an emergency situation, to act on the patient's best interest. So I think someone had said, what if there's no time to go through the courts? So maybe what if the parents have said no in an emergency situation? The parents said no. The child obviously maybe doesn't have capacity, or they've said no, but it's an emergency situation and you don't have time to go to the courts. Then in that moment, what do you do? And I believe that you do whatever is in the best interest of the child, of the person.
Yeah, absolutely. And there are very few situations where you're in an emergency and people are refusing, life-saving treatment. It is a rarity. But yeah, so when you can't get the consent of the patient or the parents to undergo a treatment, you firstly act in the best interest. So for example, if it's an emergency life-saving procedure, you act in their best interest and you assume that they would want to have something that would save their life. And then you then consider what things are necessary for now. So let's say I can do something that maybe let's say we give some blood and that brings them back, brings them to a stable condition. And then any further decisions we can take if we stabilize them, and then we get the decision after that, as long as delaying it's not going to impede their health. Okay, so the idea is that you do what is necessary, and then you can kind of buy time until you can get the decision to get that final consent.
Yeah, exactly. And like what Ash said as well, a lot of these things, like the more complex situations, someone said, how often does it occur when you have to go to court? A lot of these complex situations are not that often. They're not happening all the time. Every day in hospital, you're not having to go override the parent and do all those things. It's quite, rare cases. And a lot of them, when they do happen, they do become famous cases where things become, complicated, and then guidelines are made from them and things like that. There's the more general things of what you must know on your day-to-day basis are the things like, the basic capacity and competency of just your day-to-day. But when it comes to, refusal and, having to go over, or parents refusing and doctors having to go to, because even for a doctor to make the decision to have to go to the court is a big decision. So not a lot of the times is it happening all the time. But it's something obviously to be aware of, so what can happen. But it's not something you're encountering on a day-to-day basis.
Yeah, absolutely. So, right. let's do a case. So I'm going to put a case. If you guys, if any of you, those of you who've done a mock interview with me, will have probably seen one of these cases, but let's see. Let's go through this one first. So what I'm going to do is post the case. I'll read it out, and then I'll ask if someone is feeling like they want to volunteer and kind of unmute and show your screen, and we can talk about the case and the questions asked in it. Okay. Oh, let's see. Hold on. Let me just get... Okay. Have you guys got? Okay, is it on there?
Yeah, we got it.
Oh God, I did it twice. Okay. So, an 84-year-old lady with 84-year-old lady with dementia is admitted from a care home with urine infection. Her carer tells you that she, sorry, hold on one second, I'm going to have to put my glasses on for this. So, her carer tells you that she was seen a week ago by the doctor but refused antibiotics. She has now progressed and will need to be admitted to hospital for IV antibiotics. What ethical considerations would you need to bear in mind when proceeding with this patient? Okay, so have a think. Have a think what kind of things we've just discussed that we need to talk about, and what kind of what principles will guide us. So if anyone's ready, if anyone feels like they want to have a go and just speak up and just discuss. Oh, someone, Alexandra, yeah, sure. Yeah, unmute and just show your screen, and then we'll go from there.
Hi, Dr. Hilton. I'm Alice.
Oh, hi again. How are you doing?
I'm good, thanks. Yeah. So I just want to have a go with this question. So obviously, if the doctor doesn't go with the treatment, the infection can proceed, and as she's an old lady, it can even be life-threatening to her. So this is the beneficence side of the story. In order to, and well, non-beneficence, in order to not do harm, they have to give the antibiotics. But as she refused them a week ago, and she was deemed to have capacity, that has to be taken into account. Although her idea might have changed within a week, we can't know that, and she has it proceeded, so she doesn't have capacity right now. So possibly a proxy, if she's trying to have a proxy, then that has to be taken into account. And maybe a holistic care team can come together to make a decision for her. Maybe her family, who might know her, if her decision has changed, her family might know, and some other doctors and some people from the legal side of the issue might come together to make a decision as well. And they have to essentially just make the patient live, because that's what's essential here right now.
Yeah, absolutely. So what do you think let's say the first port of call is we ask, I'm trying to find out if there's a medical proxy, and she doesn't have one. And then we try and ascertain whether there's an advance directive, and there isn't. And let's say we don't know necessarily the circumstances under which she declined the antibiotics in the first place. Maybe she wasn't lucid then. So what principle are we going to do, and what kind of principle will guide us on that?
Well, according to the mental act capacity, she doesn't have capacity right now, so we can take that into account. And in that case, the doctors will have to make a decision for her. Possibly an alternative can be used, taken into account her decision before, the decision that she made a week ago, but we don't know the circumstances back then. As you said, she might not have the conscience to make a decision. So as I said before, doctors and a holistic team might come together, and a multidisciplinary team meeting can take place to make a decision for her in her best interest. So number of quality life may be taken into account if they give the treatment, and the kind of the disadvantages of not giving the treatment, such as can it become fatal to her, can it actually threaten her life. And yeah, on those bases, a decision has to be made by the doctors in our best interest?
Yeah, and I would suggest that maybe we don't even need to go as far as holding an MDT. Remember, I was saying that when a patient isn't deemed to have capacity, and we can't really ascertain things, but we're going to do the bare minimum, the life-saving treatment. If someone's coming in, again, we don't have all the information from the question, but assuming that someone needs IV antibiotics for a urine infection, she's probably quite septic. So that means that she's probably quite unwell and will probably, deteriorate fairly quickly if we don't intervene. So we can absolutely treat in the best interests here and give her the antibiotics, and then kind of ascertain more about, get more information, speak to the relatives. We can try and speak to the relatives if we can get through to them fairly quickly. We don't want to delay treatment too much. But yeah, absolutely. Yeah. So great, good answer, Alessandra. Well done, Alexandra. Cool. So good. Any other comments from anybody? Anybody else want to chip in with anything? Feel free to unmute. Or Nellah, do you have any comments?
I think someone called Demand just had mentioned, do we know how serious the dementia is, or we'll be told only that she has dementia? So in this case, you were told that she has dementia, but she's 84 and she has dementia. So they're trying to make you assume that she doesn't have consent. She doesn't have capacity, sorry, to make the decision. So that's how I would go about it systematically. So first deem if the person has capacity, and if they have capacity, what have they decided? And if they've decided that, what do we do? Or do they not have capacity? And if they don't have capacity, how do we ascertain that they have capacity? So go through it step by step before you even get to do we give treatment or not. It's, do they have capacity? Assess if they have capacity, and then what is their decision? And then what do we do after that? So it's a good question to ask, how much do we know about the dementia? But I would just assume that they're trying to basically make you realize that maybe they don't have capacity. So go through it systematically. But that was really good in terms of after that.
And also, when you're discussing, so an MMI station, this will be something that you discuss, and you can say, well, I would like to ascertain more. On the one hand, if she doesn't have capacity, we would do this. Whereas if this is a patient who did have capacity and is currently lacking capacity, but she was okay a week ago, then we would have different considerations. And you just acknowledge that you recognize that it could be different situations even within what's presented to you. Just know that you're not, from this, you don't know everything, so you'd want to get more information. And someone was saying, does sepsis cause confusion? Yeah, so sometimes it might not be her dementia, it might be the fact that she's septic, that she's unwell. So any acute illness, not any acute illness, but a lot of acute illnesses cause confusion. So yeah, that could be the reason that she's lacking capacity right now. Anyone else want to say anything or unmute and speak? I think we've covered most of it, but if anyone else has got any other points or questions, feel free to.
I think someone called Tale, I don't know. If you're messaging to me directly, so you might want to message to everyone. I don't know if you mean to do that, but Mariam is, a few people basically are messaging to direct message, but I think you'll mean to message to everyone. So just make sure that you're sending to everyone.
Cool. Okay, let's do one more case and then.
Yeah.
Okay.
So the second case. Are you going to post it in?
Yeah, I'll do it now. Okay, and I'll let you take the lead on this one, Nellah. Okay.
Can you post it in the thing? Because I don't know, mine's gone somewhere weird.
Yeah. Sometimes the chat goes a bit funny.
Post it in the chat. The case.
Okay, that should be there now.
Oh, there you go. Yeah, so we've got this case, we've got 50, it's a shorter one. So we've got a 15-year-old girl comes to the GP practice. So you are at the GP and is requesting oral contraceptive pill. So what are the medical legal considerations that you must take when talking to this patient? So yes, just take a moment to think about it. What is this question asking you? What does it want you to think about? What principles, what guidelines does it want you to think about before? And then if anyone wants to have a go, you can do. And then if you want to, you can just unmute yourself and then come up. So what does this want you to do? Don't be scared, guys. It's okay. It's better to practice. The more you practice, it's better to practice with us than to, yeah, Camille, yes, you can have a go, sure. Just unmute yourself and then put your camera on, if possible. You don't have to put your camera on, but you know.
Yeah. So, can you hear me?
Yeah, we can hear you.
Okay. So I think we should look at the safeguarding, because she's under 16 and that's under the legal sex age. So I feel like it's important to make sure that her partner and her are not having an abusive relationship. And then it's really important to assess her capacity. So I think the Gillick competence. So like probably making sure that she understands what like the contraceptive pills does, risk and benefits, and just make sure that she's able to contain it and explain why she would want to take it. And there was one more. Oh yeah, to assess whether if she's gonna continue sexual activity if you don't give her the pill as well, and to ask if she have told her parents and whether that this should be kept confidential.
Yeah.
Absolutely.
Yeah, go on, Ash.
It's okay, go on, you go.
What were you going to say?
So,
oh, okay. No, yeah, that was really good, Camille. So
you go. You go.
you're lagging, so I can't really hear you. That's why. So I'm like keep jumping, and then when you go to talk. So yeah. So the question was the main question of the thing is what medical legal consideration must you take into consideration? And as if you said correctly, you have to. The safeguarding is an issue. It was not an issue, but it's something that you have to keep in mind. So obviously, it would go with your history taking, talking to this 15-year-old to understand the relationship she's in, to make sure that she is in a safe and not in a physical, psychological, sexual, financial kind of like abusive situation. And then also the main guideline that you would want to look at is obviously the Fraser guideline, as we said before. So which kind of has what you already said. You said it, but you did without saying Fraser guideline, but you did say it. So it's understanding that we are to, if as long as it's safe, it's in her best interest, she's not going to continue to do this without it, then we are to give this this contraceptive pill. So it's looking at those guidelines. So does she have competency, like the Gillick competency, like you said? Is she safeguarded? Is she, in this conversation, is she safe and everything's okay? And then after that, using the Fraser guidelines, can we actually give this treatment to her when it comes to her whole situation? So yeah, you're right in what you said. So it's just kind of systematically going through those things, and then so someone says, so what's the reason she wants to have the contraceptive? That is part of that conversation you'd be having with her, because you need to have that conversation in order for you to understand if she's being safeguarded. So medical legal considerations is that whole thing about the medical side of it with the best interest, the legal side of it with her age and the competency and the safeguarding aspect of it as well. Before, when you're talking to this patient, you have to keep all of those things in mind. And then the last thing you said was about the confidentiality. So at no point, you can try and convince her to tell the parents, like you said, but if she says no, she doesn't want to tell her parents, that is her right to, and they would not know about anything about that because it's confidential, unless, again, when it comes to safeguarding, and even then it wouldn't go to the parents, it would go to the legal entities that need to do that, not the parents. So yeah, I don't know, anything else you have to add, Ash?
No, I think that's it. Obviously, you just mention the Fraser guideline.
Thank you, Camille, by the way.
Yeah.
Thank you for the feedback.
Yeah, really good. I think you did really well. You made, and I like the way you numbered your points as well. It's always good to structure your answer to say, like, there are three things that there are three issues that I've picked up here. Number one is this, number two is this, number three is this. So that's like, what they call signposting with answers. So you say, and off the topic of medical ethics, if someone says to you, for example, what are your three biggest strengths? You'll say, okay, well, I'll give you the 3 biggest strengths, which are, you know, I'm caring, I'm compassionate, and I'm hardworking, or whatever. And then you go into all of them. And that's good how the way you structured that. You said, I've got 3 things that I want to say. Number 1 is this, number 2 is this, number 3 is this. So that's a good general bit of feedback as well for structuring your answers. But if you deliver them like that, you'll do well at interview. So well done. Okay, cool. So we're going to do like final questions and answers. But before that, I just thought I would give you guys a little gift for coming and joining today. So what I've done is, I mean, like I was saying before, I've made these online courses for everybody, and it's a real like definitive, comprehensive guide, really. Because what I've done now is made 5 courses, and essentially is something for every step of the way. So it starts with an A to Z course, and that teaches you the journey, because what none of the other courses out there have is a kind of like, here's what you do at this month, here's what you do at this month, and here's what you should be doing at each stage of the medical school interview process to make sure you're maximizing your chances of getting in, doing the right things at the right stage. Because a lot of people find that they get to a certain point and they were like, oh, I should have started this 6 months ago. And it makes your journey a lot easier to have those things in place ahead of time. So that's the first one, is just the A to Z of kind of like knowing the journey, knowing all the tactics at each stage to make sure you're firing on all cylinders. Then we have a 7-hour course for UCAT, a 7-hour course for BMAT, a personal statement course, which is about 5 hours. And then we have the one that I've just finished now and that I've worked fingers to bone to make is about a 15-hour interview course. So what these have done is, I mean, these are as good as any of the courses out there. I use them to research, alongside all the experience that I've had. I kind of used them as well to kind of see if there was anything any bits that they're doing that I was missing that I could add. So I've taken all the courses that are out there that are popular and included all the information from there as well. So, you know, those ones are charging £100 per course. Now, what I'm doing as a gift to you guys is you can do all 5 of the courses for, you know, it's not a monthly subscription, it's just a one-off fee, and you can get all 5 courses for 50 quid. So I'm going to post the link to that. Now, if you guys are just doing interviews, I will do just the interview course as well, and you can have that at 50% off, but I'll give you the link here. But I'm going to post the links in the chat now. So this deal expires at the end of January, which is basically Sunday at midnight. So like I say, this is designed to be just everything you need to succeed at medical school. And it's all the online courses that you need just for £50, which is really good. And then here's the one for the interview course, if you just wanted that at 50% off. Again, that deal also expires. So if you're in year 12, I would say that now is the best time, because your medical school application starts, I would say, a year before you submit your application. So you need to start preparing the September before. And this is what I mean about knowing everything. People come, you know, quite late to the game sometimes and have a lot of catch up to do. But if you're organized, and like I say, this is why the journey is important, and that's why that course is so useful, because you can foresee all the things that you need to be doing and have that in place ahead of time. So I mean, I can't stress how much of a help that is. I always talk about when I went to a really good course called MedLink, and I'd already submitted my application, but I was about to do interviews. And I remember going thinking, oh, I should have been here last year, because they gave me so much good advice for personal statement stuff. And actually, luckily, I learned a lot from that I kind of compensated for the stuff that I should have put in my personal statement, but kind of made up for it at interview by getting those things in, making sure I said those things that I hadn't realized. So you don't know what you don't know. So this is why a course like that is just so good, because it gives you everything. So yeah, and like I say, the quality is as good as any of the ones out there. I would argue better, but my aim was always to give a very accessible resource to everybody at a really reasonable price. So that's what that is. And then if you wanted, I do one-to-one coaching, and we do like what is called the elite program, where we just essentially do one-on-one coaching and guide you through the whole process, and you have regular teaching with me and my team. And that has at the moment still has 100% success rate at getting people into their first choice medical school. So yeah, really good. I mean, it doesn't provide any guarantees, of course, and I never can do that, but you know, the track record is pretty damn good. So yeah, if you want to join that, then there's details for that as well. Okay.
Yeah, and it kind of just answered your questions as well that you were saying, because someone's like, can you tell us, you know, the things that we must do when you're applying? Well, that's what the A to Z course is for, to kind of guide you along. That's the first link that I just posted. Or even Jasdeep was asking about if it covers the GEM route, the graduate entry route. There's not really that much difference. Yeah, it covers, because you're still being asked the same things, whether or not you're applying as a graduate or you're applying as a normal student. It will cover that as well, the entrance exam. So there's not much else that you need that's not in those courses. So I'd say, to answer your guys' questions, yes, and yes.
Yeah, exactly. I mean, we have tailored stuff for whether you're graduate entry. A lot of our people on the elite program are graduate entrants, or graduate applicants, should I say? Because yeah, it is. I mean, it's slightly different, and you need to do slightly different things. And yeah, and we like help tailor for that, really. But so if you want to, I can also post a link for the what's it called, the elite program, if you want to have a look at that as well. But yeah, that's everything that you need essentially. That was the whole idea of the resource, to just give you all the resources that you need to get into your first choice medical school. So yeah, so just before we wrap up, we can do a few more questions if anyone has any burning questions they want to ask. If you want to make it more interactive and unmute and turn the screen on that. But oh, Nellah, are you done with university? That's one of the questions.
I'm actually on my placement. So in my course, we have 6 years. It's a 6-year course. So the last year is an internship year. So I'm basically working as an F1, but at the capacity of a final year medical student. So it's called a clinical attachment. So I'm in my final year, but I'm doing my basic placement. I'm basically working as a free, non-paid F1. So that's what's happening. I'm in my internship, and so I have not finished yet.
One of the questions is, good question, should you approach panel interviews and MMI interviews differently? So this year, a lot of it will kind of be panel interviews anyway, because of the online format, but you should prepare for them exactly the same. It's just the way that they ask the questions will be different. So take medical ethics. They will ask a question, like they will either paint a scenario where it's a, someone, I think it would be a bit harsh for them to paint a scenario where you are a young patient asking for contraception and you're asked to play the doctor. That's probably a bit far-fetched, but they'll in panel interviews, they'll present the situation to you and ask you to talk about it, or they'll just ask a general question like, tell us about capacity. Whereas at MMI, they'll obviously format it in a way that's a scenario. So a good example might be professionalism, where they'll say, tell us why it's important to keep your knowledge up to date, or to act professionally in your role, or why professionalism is important in the career of medicine. And you'll discuss, why it's important to keep your knowledge up to date, because obviously that means that you're treating the patients best, and to act professionally holds trust in the eye of the public, blah, blah, blah. Well, then you might have a professionalism scenario, for example, where you catch someone stealing, and you have to talk to them about that and tell them exactly the professionalism issues that are there and why it's bad to steal and the potential consequences of all that. And then even within professionalism, you might get like an SJT type scenario where you get a scenario and you get 5 options, and you have to talk through your ranking of what the most appropriate to the least appropriate thing is. And that's important more of how you talk through it and your justification of it, rather than the answers. Obviously, you want to get the answers as close to correct as possible, but it's more about how you talk through it and how you deliver that. And that's another thing on the online medical course. I taught you through exactly the process to go through to make sure that you get them maximizing the marks on those types of stations.
Yeah, I agree. I agree with that.
Cool. Any more questions? We'll have a couple more, and I think we'll wrap it up there.
So I'm just looking to see what are the questions. So what are the dates for the UCAT and BMAT courses?
As in,
I think you find
my course. My course, I'm just putting the finishing touches on the 2021 versions, but for the actual opening dates, the UCAT opens on the 26th of July this year, and we're still waiting. I need to double check BMAT, because last time they were talking about only doing one sitting, but I need to double check whether they've made any further announcements about that.
Yeah. What about work experience? What do you think we should do about work experience? If you mean about getting some now that everything's kind of shut, I think Ash I touched on this in the last webinar. Actually, a lot of the questions that you guys are asking, Ash answered a lot of them in the last webinar, so it might be worth looking at that. But and it's a long webinar, so you can still get online work experience and stuff like that. So
yeah.
I don't know if that's the question exactly.
Check out. I'll post the video in the chat of that. So just that's the YouTube of the last one.
Yeah.
But yeah, work experience at the moment. Just to quickly recap, the overarching theme from that was try and ascertain what work experience is trying to get out of you. So that is things like, exposure to medicine, seeing the realities of it, understanding whether you want to do it or not, speaking to doctors, knowing what the career is like, and find ways that you can achieve that. So virtual work experience is one option. Other things like volunteering, it will give you experience caring for people, and all those sorts of things that are kind of roundabout ways of achieving the same thing.
Yeah. And in terms of your question, Lisa, what kind of questions an interviewer is most likely to ask regarding medical ethics? The questions can vary, but it will be addressing these kind of principles that we've just mentioned that we've just been talking about in the webinar. So I wouldn't worry too much about the kind of questions in the actual exact of the scenario, but I would worry about understanding what goes into the ethics, into medical ethics in general, which is everything we've just covered in this webinar. And like Ash said, he goes into it in more detail in his actual courses about how to actually tackle these, because there's only so much we can go in like an hour.
Understand the overarching principles is that will help guide you, and at least if you show an understanding of that, then you should hopefully not go too far wrong and apply it to that situation, and that should stand you in pretty good stead.
Yeah, and I'll just ask you one more, I think, about the NHS. So how much should we know? What kind of questions involving the NHS are interviewers most likely to ask? Yeah,
so again, covered in detail, but so again on my YouTube channel recently, I don't know, Nellah, because I guess you're not very you have done a bit in the NHS, but you're not that NHS orientated, are you? So
no.
I've literally just released a short series on YouTube of all the things that you need to cover. So it's like a 10-minute summary of it. So I've already released the NHS one, so have a look on there, and I'm still releasing a lot of those videos, so make sure you subscribe so that you don't miss them. But okay, cool. So I think we will leave it there. So I'd like to thank you guys all for coming, really appreciate it. And like I say, if you want to check out those courses, feel free to do so. But I'd like you to just take a moment to thank Nellah, because she's absolutely amazing, and she's done a great job here. So just in the reactions, you can do a little round of applause, and just, that's it, go crazy in chat. And the reactions, if you hit reactions in the bottom right, you can do a little round of applause, and then it showers the screen with claps and stuff. So that looks really good as well.
Thank you, guys.
Yeah.
You guys have been awesome too. You've been really engaged and everything. So That's good. It shows that you're initiative and you're really interested. So that's a good thing.
Yeah, exactly. And that sort of, you know, enthusiasm and hunger for knowledge, that's what's going to stand you in good stead for the interview itself. So well done, guys. And I'll just post those links to those discounts on the courses one last time. And yeah, I'll be putting this up on Friday, probably about 4 o'clock on Friday. I'll do it. So yeah, just let's see. So there you go. Those are the links are there in the chat if you want to get them just before we wrap up, because you'll lose them after that. And then I'll email them to you. But yeah, so if you're watching the replay, I'll put the links in the comments below. And yeah, comment, ask me questions. If there's any questions that we haven't answered here and you want me to answer them in the recording that I post on YouTube, just put them in there, and I'm very active, so I'll always answer them. So, okay, guys. Well, thank you very much. Thank you, Nellah.
Thank you for having me. This was really good. And I just read Lynn just said I feel so much more confident, and that's the whole purpose and that's the whole aim. So I'm really happy for you guys. And yeah, just I would say just the last thing is, like, a lot of you guys, the questions that you're asking, especially on Ash's YouTube, they're already there. If you don't have them. So thank you for having me, and thank you for this lovely webinar.
Nah, it's my pleasure. All right. Thanks, guys. Thanks, Nellah. Take care, everyone. Bye.